So since we've established that 6-step framework previously with the EKG and the heart failure that we did before, this part here that we're about to do today should tackle a high stakes rhythm that creates the perfect contrast to AFib, ventricular tachycardia. Okay, VTach is the best choice because it moves the problem from the top of the heart, which is the atria, to the bottom, which is the ventricles. So this changes the urgency and the treatment. If you see this on your patient's monitor, you don't call the doctor, you run to the room. Okay, this is again ventricular tachycardia, and it's the one rhythm that will absolutely make your heart drop as a nurse. Before we break down the patho, right? Make sure you're following this. Make sure you follow so you can master Med-Surg one disease process at a time. Like, comment, share, do all the things. Okay. Remember our foundation. In a normal heart, the QRS complex is that big squeeze where the ventricles pump blood to the body, right? So it should be narrow and sharp. But in VTach, that squeeze is happening way too fast and it looks completely different. So let's use our 6-step Med-Surg framework to understand why VTach is a life-threatening emergency. So here's the disease process, aka the patho breakdown. All right. So VTach is a rapid, regular rhythm originating in the ventricles. So basically, the bottom of the heart takes over as the pacemaker. Because the signal isn't following the normal path, the ventricles beat so fast they don't have time to fill with blood. So on your strip, you'll see wide tombstone-looking QRS complexes, and you won't see any P waves at all. Okay. Number 2. That was number 1. This is number 2. Risk factors. Who is at risk? Usually patients with a history of MI, which is myocardial infarction, heart attacks, right? Cardiomyopathy or heart failure. But for your exam, watch out for electrolyte imbalances, specifically low potassium or low magnesium. So those are huge triggers for ventricular irritability. Number 3. Clinical manifestations. How is the patient responding? This is the most important part. Okay, some patients might be alert but feeling chest pains and shortness of breath, while others will lose consciousness instantly because their cardiac output has dropped to nearly 0. All right, the first thing you do is check for their pulse. VTach can have a pulse or it can be pulseless. Okay, number 4, diagnosis. So we diagnose this with a monitor or a 12-lead EKG. You're looking for a rate usually over 150 beats per minute, a wide and bizarre QRS complex greater than 0.12 seconds, and no P waves. It looks like a row of sharp mountain peaks, right? Number 5, treatment and interventions. Treatment depends entirely on one question. Do they have a pulse? If they have a pulse but are unstable, we prepare for synchronized cardioversion. If they have no pulse, you start CPR immediately and prepare to defibrillate. Remember, S for sync if they have a pulse, and D for dead if they don't. Okay? It's not funny, but we got to use what we got. All right? So teaching. If they survive VTach, they need to know why it happened, right? So teach them about the importance of their anti-arrhythmic medications. If they're getting an ICD, that's an implantable cardioverter defibrillator placed, teach them to avoid strong magnets, carry their ID cards, and teach them what to do if the device actually fires or shocks them. That's how you master VTach using the 6-step method. What are we doing next, guys? Are we going to do COPD? Or do you want to do... Just let me know in the comments what you want me to do next, okay? And remember, I'm going to always leave you with this. Never, in this lifetime or the next, dim your light for anyone. Stay lit.